Hello, friends. Dave Bjork here, lung cancer survivor, patient advocate, and host of the Research Evangelist podcast. I recently just got back from the ASCO annual meeting, the largest oncology conference in the world, and I'm doing a series of short interviews to provide some interesting research from ASCO for patients who could not attend. The series is supported by an unrestricted educational grant from Nuvation Bio. And today, I've invited Dr. Tony Mock, a medical oncologist, professor of clinical oncology, and chairman of the clinical oncology at the Chinese University of Hong Kong, to tell us what we need to know about the 7-year update from the phase 3 CROWN study. And I was actually at the plenary where it was presented. Dr. Mock presented this data at the lung cancer plenary session at the ASCO meeting in Chicago. So I'm really excited to have you on the show. Thank you so much, Dr. Mock, and welcome to the program.
Thank you so much, Dave, for the kind invitation. It was a great meeting, and we learned a lot from different so-called presenters.
We definitely did. A lot of great information came out at the conference. So, let me just start by having you just tell us about the study, and tell us, what patients need to know about the data that was presented at ASCO.
Certainly. CROWN is actually an old study already, and now we're talking about the 7 years data. So this is a randomized phase 3 study of a drug called lorlatinib, which is a third generation ALK inhibitor, versus the first generation crizotinib in patients with stage 4 ALK positive, including brain metastases, and actually approximately 30% of patients actually have brain metastases. Randomize them 1-to-1 either to lorlatinib or crizotinib. So the first data set was presented back in 2020 in New England Journal of Medicine. We have a nice hazard ratio, but we didn't reach median because doctor and patient like to know the median because that is the one number that click in your mind, although it does not represent the patient, but it's a landmark, a type of a reference for the patient. So we wait and wait. 2024, we had the 5-year data, and then at that time we had a hazard ratio 0.19, but we did not reach the median yet. So we decided let's continue to follow up. Now, why do I say that we have continued? Because it's costly to do the follow-up because we have to do the scan of the body and the brain, including MRI, on a regular basis. So the decision is to continue this process, and now with the 7 years data. Now, at 7-year data, the key message as follows. First of all, we still have not reached the median. So at 7 year, 55% of the patients are still progression-free. So meaning that more than half the patients are still on the drug and have no evidence of progression at 7 years. The second implication is that if 55 patients did not reach a median at the 7 years, the median progression-free survival must be more than 84 months. And now that's remind us with anatinib, the median progression-free survival was actually 34.5 months. So it has to be double or more of the median progression-free survival, although we don't have the number for the median. That's number one message. I think that's important. The number two important message for the patient is this: is that now I got ALK-positive for stage 4. Now I was put on lorlatinib. When do I know that I'm going to be okay? Because patients want to predict the future. You may want to buy a home, you may want to get into business, but how do I predict my future? This is a question for a lot of the patient. So we look at the risk of progression year by year because we're the first study who had the 7-year data. So the first year, there's about 20% chance of having progression. Second year, 10%. But that means that from the second year onward until 7 year, every year is about 2 to 5% only. So the chance if you're progression free at the second year, the chance of having progression at the 7 year is actually the chance that you don't have a progression 7 year is actually 79%. So in a sense, you're already on the drug for 2 years, you don't have progression, you got about close to 80% chance you're doing fine by the time you reach 7 years. So I think this is a very reassuring information for the patient if they have the situation and on this drug. The third part is that protection of the CNS, because this drug was what we call the microcyclic compound, which has a high penetration to the brain, and we try demonstrating that by doing repeated MRI every 8 weeks for the first 5 years and every 16 weeks for the next 2 years. So this patient, we got a very close monitor of the brain. And as an overall result is that after the 3rd years, that the so-called progression-free rate was 92%. And then it stayed as a 92% all the way until the 7 years. So in other words, if you don't have any progression in the brain by the third year, you'll be pretty good, for the rest of the 4 years of time. And then especially for the patient without the brain met, that is up to about 96% chance that you don't have a CNS progression. So those are the three main points patient will take away. Is number one, we got longer progression-free survival. Second part is that if you're good by second year, you got a pretty good chance you'll be fine by 7 years. And the third is that there is actually high CNS efficacy. So those are the 3 points that I think your audience should remember.
Yeah, and that 7 year of that figure you just mentioned about the 79% likelihood of remaining progression free at 7 years is, when I heard that in your presentation, I was just blown away, because I know it was a couple of years ago at ASCO, it was the 5 year. I think I got a standing ovation at ASCO, with the 60 months. So
Yes,
this is
yes.
this is really quite remarkable, right?
Right. Ben Solomon presented that in the 5 year in ASCO, and now we have these 7 years data. And this year, ASCO, the standing ovation is for pancreatic cancer, which is exciting as well. I
That's
really love that one.
that was the KRAS one, right?
That's the KRAS run, yeah.
Yeah,
That was
yeah.
a what we call a pan-KRAS inhibitor for pancreatic cancer. And why I also mention it, because we have ongoing study of this pan-KRAS inhibitor for lung cancer as well.
Oh, that's amazing. Yeah. That's very exciting. And of course, with pancreatic cancer, that gives hope to a lot of patients where there's not a lot of hope, and so, the presentation that you gave gives us hope in the lung cancer community, particularly those, that are ALK positive, who are, getting this medication. Still a lot of work to be done, of course, right? And I appreciate the work that you do, to continue moving this research forward. So thank you for all that you do. I really appreciate it.
Well, it was my great pleasure. We didn't know anything about L mutation until 2007. So in this past 19 years, you got a so-called the fortune of involving in the first generation, second generation, now the third generation, and looking forward for the fourth generation. And hopefully with each new drug, will bring new hope to our patients.
I love that. I love that. Well, thank you so much. I really appreciate you coming on the show. And again, from the bottom of my heart, thank you for everything you do for the lung cancer community. We really appreciate your work. And so thanks again for being on the show.
Thank you, David. Thank you for the opportunity. You have a good day.